Good morning. Today's lecture topic is supposed to be lymphatic disorders. Lymphatic disorders mainly affect lower limbs and it results in chronic edema of the lower limbs. But for chronic edema of lower limbs, lymphatic disorders are only one cause. There are several other important causes. Therefore, I thought of discussing it as chronic limb swelling with some other important causes. Let's see what are the causes for chronic limb swelling. There are venous causes, there are lymphatic causes, and there are general causes, tumors, drugs, and dependency. So if you take lymphatic causes, they are primary or secondary. Primary means there is some structural or functional deformity of lymphatics. Secondary means those dysfunction as a result of another procedure or disease. And if you take venous diseases, there may be primary varicose veins without any obvious precipitating factor. There may be primary deep venous incompetences, but this is very rare. And you can get post-thrombotic syndrome, that is after the DVT you get loss of valves which leads into chronic venous hypertension. And when we discussed vascular malformations, we noted arteriovenous malformations are known to cause distal edema. If you take general causes, there may be lipedema, that is part of general obesity, congestive cardiac failure, pretibial mixed edema, nephrotic syndrome, hepatic failure. All these causes are medical causes and you will learn them in your medicine lectures and clinical works. Tumors, pelvic tumors causing extrinsic compression on veins as well as lymphatics, which is known to cause chronic limb swelling, as well as drugs and dependency. But today we are going to discuss first the lymphatic causes, lymphedema, and then venous diseases and their complications and how to manage them. Let's see what is lymphedema. Lymphedema can be defined as progressive swelling of limb that occurs when the lymphatic system fails to transport fluid via lymphatics and lymph nodes. From your physiology knowledge, you know your capillaries leaks and that tissue fluid is drained via lymphatics. If there is some obstruction or some failure of transport of that tissue fluid into via lymphatics into the cardiovascular system, there is accumulation of lymph in the lymph. So that is called lymphedema. As we saw in the classification of chronic limb swelling, lymphedema either may be primary or secondary. Some time back, when you consider secondary lymphedema, you saw a lot of upper limb lymphedemas on patients who underwent mastectomy and axillary clearance, as well as patients who underwent radiotherapy for cervical cancers. But nowadays the treatment has developed and you see these secondary lymphedema less common. There is a classification system of lymphatics according to their functional disability. This is not very important. I included this just for the sake of completeness. There may be obliteration of lymphatics, so no lymph transport occurs. There is proximal obstruction, that is mainly in groin and axillary lymph nodes. And third category is valve dysfunction and hyperplasia. Here, as in your venous system, there are valves in your lymphatic system which prevents regurgitation, but when those valves are not functioning, lymph tend to accumulate in dependent parts. In hyperplasia, the lymphatics becomes large therefore valve will not work so as same as in your varicose veins. What are the causes for lymphedema? Let's consider primary lymphedema first. It may be congenital, precox or tarda. In congenital variety, the lymphedema occurs in infancy, that is less than first year of life. When it is familial, we call it Milroy's syndrome, but majority of cases are non-familial. Then the second category, lymphedema precox. Here the lymphedema manifests below the age of 35 years. It may be familial or non-familial. The third category is lymphedema tarda, which occurs above the age of 35 years. When you consider secondary lymphedema, the causes are malignant diseases. When malignancy infiltrates lymphatics and lymph nodes, lymphedema occurs as a result of surgery. I mentioned earlier, after radical mastectomy, you saw a lot of upper limb lymphedemas earlier, and radical groin dissections, that is block dissections of groins, for example penile carcinoma. Radiotherapy I mentioned, especially for cervical cancer and in early days for prostate cancer. Infections. This is one of the most important causes for lymphedema in our country. Maybe parasitic filariasis, which is less common now, but pyogenic causes. Recurrent cellulitis can result in chronic lymphedema. Tuberculosis is another cause. Impairment of lymphatics occur as a result of heart injury. You know, lymphatics are very closely associated with your neurovascular bundle. So when you dissect artery, invariably you will damage some lymphatics, and that might result in lymphedema. Venous disease and venous surgery, especially varicose veins. When you strip varicose veins along saphenous vein in thigh, invariably you destroy some of the lymphatics. That might result in chronic edema later. When you come across a patient with chronic lymphedema, at presentation it is important to differentiate it from other causes. For example, like varicose veins, where the treatment is different, and you need to identify a cause. That is, you may not be able to correct it, but you may be able to prevent further complications from that particular cause. What are the symptoms the patient might present with? They may complain of slowly progressive limb swelling, but they will not notice that. Instead, they will come out with their difficulty in wearing footwear. This lymphedema generally starts from the most distal part, that is in your lower limb, foot, and it is progressive during day and during prolonged standing. It might go down little bit during night and resting, but when you compare it to venous disease, this reduction is not very significant, and generally it is not painful. Sometimes acute edemas, maybe DVT, is painful, but this lymphedema is rarely painful. Instead, the patients find it difficult to walk because of the heaviness of legs. And in history, you should look for causes for secondary lymphedema. When you elicit signs in a patient with chronic limb swelling, the first important thing is whether this edema is confined to one leg or both legs. That is, whether the limb swelling is unilateral or bilateral. Depending on the cause, it may be bilateral or unilateral. And if you are lucky to examine the patient at the initial stage, you will notice pitting. Pitting is when you compress it against a bony prominence. There is a depression which persists for several minutes after you remove the pressure. But later this lymphedema becomes non-pitting. It becomes non-pitting as a result of hypertrophy of adipose tissues with chronic limb swelling and subcutaneous fibrosis. This fibrosis occurs as a result of chronic inflammation by accumulation of excess fluid in the subcutaneous tissue. The lymphedema is uniform. It affects at the same intensity right through the lower limb, but depending on a joint, you might see several humps. For example, the buffalo hump you see in foot, which is separated basically from the swelling of the leg. That is due to the ankle joint. And you will see port branch appearance. Classically, this port branch appearance is described in breast carcinoma. Again, the cause is same, that port branch appearance occurs as a result of obstruction of dermal lymphatics. In lower limb also you get port branch appearance as a result of blockage of lymphatics. And when you have lymphedema for a longer period, your skin becomes hyperkeratinized. When hyperkeratinized skin is there for a longer period, it becomes very dry. As a result, there are fissures appearing in your skin. Skin becomes thickened as a result of hyperkeratosis, and it resembles that of a tree trunk. At the same time, it becomes less elastic. And in dorsum of foot, you get a buffalo hump classically. And occasionally you get chylous vesicles. These are fluid-filled vesicles which ruptures spontaneously and starts leaking lymph. When you compare it with venous disease, the ulceration is less common. Main role of investigations are to exclude other causes and to confirm the possible diagnosis. First, we'll consider duplex ultrasonography. It is important to exclude chronic venous insufficiency, which is the other main cause of chronic limb swelling. And sometimes you may be able to elicit the changes in dermis and subcutaneous tissue. Lymphoscintigraphy will confirm your diagnosis, and it will demonstrate where at what level the obstruction has taken place. So in lymphoscintigraphy, what you do is you inject radio-labeled colloid into one of the toe webs in your lower limb, and then after that Here the patient is placed under a gamma camera and the images are taken every 5 minutes, and later those images are processed and imaging is taken. So it has a very high sensitivity and specificity. These are the imaging of a lymphoscintigraphy. Here you will see lymphatics. The radiolabel isotope is concentrated in urine, bladder, and you can see the right lower limb. There is accumulation of lymphatic, the accumulation of radiolabel colloid, and there's a hot spot, and after that rarely any transmission beyond that. So the obstruction is at the level of groin in this case. If you do a CT scan, this lymphedema will manifest as the honeycomb appearance. It's confined to the subcutaneous tissue. The tissues deep to the deep fascia is normal. And if your resolution is sharp, you will see dilated lymphatic channels. The CT scan mainly can be used to monitor the treatments. For example, if you are doing conservative management, you can do serial CT scans to objectively measure the efficacy of your treatment. MRI scans same as your CT scans, but it's expensive and generally not commonly used. These are the other possible investigations can be done on patients with chronic lymphedema, but these are mainly of academic interest rather than in clinical use. Do we need to treat the patients with chronic lymphedema? Yes, we need. That is to reduce their complications and morbidity of the patient. So our aims are to reduce limb swelling, to keep the limb as much as possible as a normal limb, reduce the risk of infections. These lymphedema legs are more prone to get infections, and with recurrent infections it acts like a vicious cycle causing more lymphedema, and you need to improve the functions. In elephantiasis, the patient's mobility is greatly restricted. To achieve these aims, you have to start your treatment early, and if you are successful and if you are able to achieve a good improvement, then you and patient both should try hard to maintain what you have achieved. There are several things in general you can do in managing a patient with chronic limb swelling. Counseling is very important. You have to give in detailed account of their disease and what are the treatment options and what are the outcomes they should expect. Here it's very important to get the compliance of the patient. In order to get the compliance of the patient, you have to give realistic information about the disease. The patient should not have unrealistic expectations, but they should work with the medical personnel to achieve a final goal. You can elevate. Sometimes this is not practical, but as far as possible, if the patients keep their limbs elevated above the level of heart at initial stages, it will reduce the persisting edema, as well as it will reduce the rate of development of chronic lymphedema. Doing exercise is very important. It keeps the patient's mobility, as well as it will help in draining some of the lymphedema fluids. Food care advice plays a major role. In coming slides you will notice what an infection can do for a established lymphedema. Manual compression therapy. By far, this is the most effective and most practical method of treating chronic lymphedema. Ideally, this has to be carried out by a physiotherapist, but you can teach a patient and a caregiver how to do this. This is very simple. What you do is you improve tissue fluid draining into the normal parts of the body. You start squeezing the limb, squeezing the whole limb above the proximal limit of the lymphedema, where you get normal lymphatics. When you squeeze, the lymphatics in that normal region will be drained to the more proximal parts, and then you gradually come down little at a time. So sometimes in initial stages you will see how the fluid moves along the limb. Then gradually you come down little at a time, and this enhances lymphatic flow. But once you do this, maybe for several weeks, you may be able to reduce the size of the limb significantly. But if you don't act any further, in no time the edema fluid accumulates again. So what can you do next? Easily you can apply some external pressure, so it will prevent accumulation of fluid within the emptied lymphatics. Earlier we used to do this using crepe bandages, but the compliance is a problem and it's not very effective. So they have developed stockings called graduated pressure stockings, which exerts maximum pressure in the most distal part and then gradually reduce the pressure to more proximal parts. So all the time it will facilitate lymphatic drainage from distal parts to the proximal parts. To be effective, they needs high pressure. Ideally speaking, you need 50 millimeters of mercury or high, but with that pressure, compliance is a problem. There are several classes of graduated pressure stockings. Class 1, 2, 3 and 4, they exert different kind of pressures, and their indications are also differ slightly. In class 1 it is less than 25 millimeters mercury, class 2 between 25 to 35, class 3 35 to 45, class 4 45 to 60. In previous slide we noted that you need about 50 millimeters mercury of edema, but with this grade 4 pressure stockings the compliance is much poor. Most of the patients tolerate class 2 compression stockings, and that is what we practically use on most patients. Intermittent pneumatic compression. This is more theoretical than practical, where you apply sequential air cells to your lower limbs, and the distal most one is inflated first and then the proximal ones. It exerts about 80 millimeters of mercury pressure, and to be effective this needs to be done 4 hours a day. So the patient has to be on a bed for 4 hours a day, and you need these hi-fi gadgets, but since it's not very practical. You can try thermal treatments. These are carried out by physiotherapists in their physiotherapy departments. You apply some microwave heating into the limbs and then immerse it in hot water, and these measures are supposed to reduce the local inflammation, which ultimately end up in more lymphatic drainage. Another mode of treatment carried out by physiotherapists is called complex decongestive physiotherapy. It is carried out over a period of 1 month in 2 stages. And if you go through them, there is nothing new, but it's also a form of manual compression therapy, which is done in an orderly manner. Generally, for an infection, the entry of port is a skin crack. Therefore, it is very important to prevent skin cracks developing and treat whatever the skin cracks which are there. So you need to keep the moisture of the skin. You can apply a mild moisturizing cream, for example like Vaseline, and the patients should wash their feet with mild soap which is not irritant and allergic, and with water. Once they wash their feet, they need to keep them dry. If you keep the moisture, it will macerate the skin, which promotes an infection. And they should wear well-fitting footwear. So if their footwear exerts more pressure on particular side, it might lead into a development of callosity and later an infections. They should pay particular attention to toe webs, because this lymphedema affects most distal parts evenly. Their toes are like squares. They can't see their toes unless they were separated forcefully to see the toe web. Therefore, it's very important to keep them dry. You can advise them to keep a cotton bud or something in between their toes. Antibiotics and prophylaxis, we discussed about it in previous slide. Drugs, are they effective? No. No drug is shown beneficial in reducing edema. Some people have given diuretics at early stage, but the effect is temporary. And if there is evidence of infection like filariasis, there is a place for relevant treatment. Surgical treatment is the last resort, where you do some bail-out procedures to try reduce the size of the limb. There are two kinds of procedures: reduction procedures and bypass procedures. Let's see what reduction procedures are first. There are several procedures described, but here I will elaborate more on two types of procedures. In Homan's procedure, you remove a block of tissue like a wedge of the affected part, and then that part is primarily closed. Outcome temporarily good, but unless you maintain external pressure, they might go back to the previous stage. Here the wound healing is a problem. In Charles' procedure, you remove all the tissues up to deep fascia, that is skin and subcutaneous tissue, and then you do a primary skin graft onto the deep fascia. Theoretically, you remove all the lymphatics, but again the outcome is not very satisfactory. There are several procedures described as bypass surgeries. Here the aim is to bypass the obstructed part of lymphatics. So they have developed lymphatico-venous anastomosis, lymphatic anastomosis, enteromesenteric bridge, omental bridges, but none of these procedures have shown to be effective. The other main cause for chronic limb swelling is chronic venous insufficiency. What happens in chronic venous insufficiency? Your venous system fails to do what it's supposed to do. The venous return is impaired. In addition, the venous hypertension occurs. Normally, in your venous system, there are valves which compartmentalize your veins in erect posture. When these valves fails, there is a longer fluid column or blood column exert pressure at your dependent parts, and this later leads into clinical complications. What are the clinical features of chronic venous insufficiency? Mainly it is swelling. The swelling is due to accumulation of edema fluid. But remember, there is no impairment of lymphatic system, just accumulation of fluid. Initially it is pitting, as in your lymphedema, but later, rather than hyperplasia of subcutaneous fat tissue, there is subcutaneous fibrosis and induration. This makes your leg bit harder when you compare it with lymphedema. The skin changes are slightly different from that of lymphedema. They are dry. They have a dry, scaly, itching skins. It becomes very friable, and because of that, it tends to get traumatized even by a very minor trauma, and that leads into infection and later ulceration. And pigmentation also occurs. This pigmentation is supposed to be due to deposition of hemosiderin. In chronic venous hypertension, red blood cells escape into the subcutaneous tissue. Then they degrade and causing hemosiderin deposition. That is the reason why their limbs are dark. Unlike in lymphedema, patients with chronic limb swelling as a result of chronic venous insufficiency generally come out with pain. They complain they have a general ache or heaviness of the limb. Sometimes they describe it as a bursting type pain, and this is more after a prolonged period of prolonged standing or after prolonged walking, and it worsens towards the end of the day. And when the patient stops walking and keep their legs elevated, it starts to go down, but it might take hours for a complete loss of pain. Then they can get ulceration, but remember these symptoms doesn't occur in this sequence: swelling, pain, eczema, ulceration. They don't occur in that sequence. They can occur haphazardly. Anything can occur first. So ulceration commonly affects the medial aspect of the ankle, where maximum venous hypertension exerts. This is classically medial aspect of ankle, but it can occur around the ankle even on lateral aspect. Generally, this is surrounded by or sometimes preceded by eczema and pigmentation. And commonly these ulcers occur as a result of very minute trauma. Most of the time, the patients may not have noticed what has happened. Some facts about the epidemiology. Generally, the prevalence differs from society to society, but it is said to be in between 2 to 9% of the total population, and males are affected more than females. However, more females present than males. This is because for cosmetic reasons. And ulceration occurs in about 1% of the patients. And once you have an ulcer, it tends to last for a longer period, generally for about a year or so. And most of them, about 70%, have recurrent ulcers. What are the causes for chronic venous insufficiency? It may be superficial venous reflux. Superficial venous reflux, or in simple words, varicose veins. Varicose veins affect either your long saphenous venous system or short saphenous venous system. So when you examine a patient, this is the first sign you should elicit the affected territory. It may be due to deep venous reflux and ulceration. Rarely this may be primary, that is, there is functional defect of the vein and its valves, but more commonly it is secondary to DVT and injury, and there may be perforated vein reflux. It may be due to abnormal calf pump as a result of neurological or musculoskeletal problems, or combination of above. What are the pathophysiologies behind the chronic edema and ulceration? It is not 100% known what is the exact mechanisms, but there are several theories. In WBC trapping theory, white blood cell trapping theory, the white blood cells, they tend to adherent due to the stagnation to the venular ends of the capillaries to the endothelium, and once they adhere to the endothelium, they are activated, so they release cytokines, and these cytokines in turn exerts inflammatory reaction, ultimately end up in damaging the endothelium. This damage increases the permeability of capillaries and small venules, so fluid will leak, and edema and ulceration develops later. The other one is fibrin cuff hypothesis. So in what happens in fibrin cuff hypothesis is, due to sustained venous pressure, the venular ends of capillaries elongates. So the intercellular gaps between endothelial cells also increases. When you have large pores in between cells, large molecules like fibrinogens escapes into the tissues. Once the fibrinogen escapes, it becomes fibrin, and this fibrin is deposited around capillaries. Therefore, the thickness of capillary wall, vessel wall increases, and it causes less oxygen diffusion and tissue ischemia, which ultimately result in cell death and ulceration. In addition, in your Bailey and Love, there's another theory. When you have sustained venous hypertension, it opens up arteriovenous shunts, and once arteriovenous shunts are opened up, it causes edema and ultimately resulting in ulceration. What are the investigations you can carry out in patients with chronic venous hypertension? You can first you can do handheld Doppler study as a bedside procedure. You can hear a venous hum as a sea breeze. So when you squeeze, you will hear, when you squeeze cough, you will hear blood going up. It should not come back when you release it, but in chronic venous insufficiency, you will hear a refluxing sound as well. Duplex scans. This is becoming the gold standard for chronic venous insufficiency. Here, basically what you look for is the compressibility. If a vein is compressible, then that means there is no deep vein thrombosis, and you have to see the direction of flow. Generally, it has to be caudal to cranial direction. If the blood flow reverses, that means the valves are not functioning properly. Venography. Nowadays we don't do venographies under normal circumstances. It's invasive and you can get reactions, allergic reactions, and sometimes anaphylaxis to the contrast. You can check calf volume measurement to assess the amount of edema, but this is more academic than practical. So how do you manage a patient with chronic venous insufficiency, and particular a patient with a wound? First, you have to optimize all the factors affecting wound healing. Once you develop a venous ulcer, it becomes multifactorial. That's why you need to improve all the factors affecting wound healing. Just to go through the factors affecting wound healing again, these are the factors. If you try to remember them as local factors as well as systemic factors, it's easier. So you can go through the factors affecting wound healing now. The specific measures for get rid of venous ulcer is to remove venous hypertension. You have to come to this stage provided you have corrected all the other factors affecting wound healing, as I mentioned earlier. So how do you specifically remove this venous hypertension factor? So you can do elevation or you can do compression. These are temporary measures. If you want to try elevation, what you should do is you have to keep the affected part above the level of heart. So gravity will drain out excess fluid and there is no venous hypertension. You can do this by asking the patient to be on the bed with lower limbs elevated. And if you keep the patient like this for most of the time a day, in about 1 month or 1.5 months, the ulcer will heal spontaneously. But for obvious reasons, this is not practical. So to achieve the same thing, we apply external compression. So the veins are emptied all the time, even during their walking and erect postures. So let's talk about more how to get rid of a wound. You need to correct all the factors affecting wound healing, and then now we are going to reduce the chronic venous hypertension. So before apply compression, we need to make sure that there are no underlying infections. For this, your clinical judgment is sufficient most of the time, but if you are in doubt, you might have to do some microbiological studies like culture and antibiotic sensitivity, and if there is an infection, you have to treat that infection first. And before applying external compression, you need to make sure there is no peripheral arterial disease. If the patient already has peripheral arterial disease, if you apply external compression, it will impair the distal circulation further, aggravating the condition more. Again, if you are in doubt, you can check ankle brachial index. If it is good, or that means if it is more than, for example, 0.8, you can go ahead and apply external compression. This is a picture of a handheld Doppler which is available in most of the wards nowadays. This can be used to assess your varicose veins, as well as you can use this to check ankle brachial index. Then you start applying compression dressing. First you have to clean the wound thoroughly, and then if available you can use commercially available dressing materials like inadine, biofil or intrasite. But if you don't have anything, just use normal saline soap gauze, and then on top of that you apply absorbent materials, because these wounds tend to ooze a lot. So when you want to keep the dressing for several days, you have to apply ample absorbent materials, so it will absorb all the exudates coming out of the wound. And on top of that you apply compression. You have to apply even compression, maximum at the most distal part and gradually coming down as in your graduated compression stocking. So what you do is you apply a layer of cotton that will distribute the pressure evenly. On top of that you apply 2 layers of crepe bandage, and on top of that you apply elastoplaster, which is the adhesive elastic bandage which keeps those previous bandages intact. When you apply this pressure, you need to make sure you don't apply too much pressure, and you have to advise the patient, if patient develops numbness, any bluish discoloration of the distal parts, they should immediately remove the dressing and come and seek medical advice. As I mentioned earlier, it has to be graduated compression, maximum on the most distal part and then coming down. And the pressure depends on the number of layers. So more the number of layers, more the pressure they exert, and that's why sometimes it is called multi-layer compression dressing. Once you apply the compression dressing, you need to change it from time to time. So what is the frequency? Generally you can go up to 2 weeks, but that depends on the amount of exudates. If the wound becomes wet as a result of the dressing becomes wet as a result of this exudate early, then you might have to change it early. Otherwise you can go up to 2 weeks. Then you need to correct the underlying pathology as soon as possible. if the cause is varicose veins, then you have to treat varicose veins, and if the cause is chronic venous insufficiency, you need to take measures to counteract chronic venous hypertension for life. Some people start doing this step as the first step, but it's better to wait until the wound becomes stable or healed. And that's the end of the lecture. Most of these things will be covered again when you come to do clinicals, and most of these limb swelling cases will come as short cases, and you might get theory questions on that as well. Thank you.